Thank you for the opportunity to share with you a case study developed by Cindy Heath, Justin Holbrook, Nancy Kienka, and me, the narrator, Kathy Kirk. This was a valuable learning experience for our team, and we hope to enhance your understanding of the pharmacological management of atrial fibrillation in the outpatient setting. In this presentation, the objectives are to review the history, current medical information, and the plan of care for the selected patient, review the pharmacodynamics and pharmacokinetics for the prescribed drugs, discuss the pertinent information about each drug in relation to interaction and safety issues, identify current best practices for monitoring the prescribed drugs, look at how we might go about meeting the teaching learning needs that would be unique for this patient, and finally, explore any clinical problems related to the prescribed drugs while offering potential solutions to address these concerns. As we talk about this case, there'll be some details of his history and care that we don't know. He was seen by a cardiologist who, of course, focused the care on the pressing issues related to his presenting symptoms. If we were caring for him as his primary care provider, we would need to ensure that we had access to the big picture in order to provide holistic care. We'll note in our discussion information that's missing but would be very pertinent when he was seen by the family nurse practitioner. Our selected patient is a 53-year-old Caucasian gentleman who presented with classic signs of atrial fibrillation, namely heart palpitations, lack of energy, dizziness, chest discomfort, and shortness of breath. Just as a review, it's important to understand that atrial fibrillation is the most common irregular heart rhythm that starts in the atria. Instead of the SA node directing the electrical rhythm, many different impulses rapidly fire at once, causing a very fast, chaotic rhythm. Because the atria are beating rapidly and irregularly, blood does not flow through them quickly. This makes the blood more likely to clot. If a clot is pumped out of the heart, it can travel to the brain or kidney or other vital organs, resulting in major damage. People with atrial fibrillation are 5 to 7 times more likely to have a stroke than the general population. This patient has a past medical history of chronic atrial fibrillation, hypertension, coronary artery disease, hypothyroidism, and depression. As our team reviewed the information we had on this patient, we quickly realized that he presented with some unique social and personal issues that would impact his care. Namely, he had some limitations to cognitive functioning, which may or may not be related to the other parts of his personal story. He's divorced, unemployed, and does not live independently. He receives income via Medicare and Medicaid, so he is able to receive care for his medical needs. As I stated earlier, we have some pieces missing regarding his personal and medical history. His actual level of cognitive functioning is one of those unknowns. Based on clinical interactions in comparison to general criteria for the diagnosis of mental retardation, the case study team determined he would likely be in the range of mild mental retardation. This will become important as we talk later about how to provide education and plan for follow-up.